528 infections and 490 deaths driven by the rare Bundibugyo virus strain. This epidemic marks the DRC's 17th Ebola outbreak. The World Health Organization has decided, or rather declared the outbreak a public health emergency of international concern. And we speak to Dr. Patrick Otim Ramadan, Program Area Manager at the World Health Organization, AFRO, for the very latest. A very good morning to you, and thank you so much for speaking to us, Dr. Otim Ramadan. Let's start with the latest figures. What we have just quoted is that the most latest up-to-date information. And from an epidemiological point of view, can you just tell us what you're seeing in terms of the trajectory of the disease and the containment measures? What is working, what is not working?
Thank you very much for having me, and good morning to the viewers. In terms of the latest epidemiological figures from the National Institute of Public Health in DRC, we have now crossed the 1,500 mark. We have 1,561 confirmed cases with over 500 deaths, which is 506 deaths, really giving us a case fatality of 32%. The outbreak is still being reported from 3 provinces. However, we have some good news in that one of the 3 provinces, that is the South Kivu, has been inactive, as they have not had any new confirmed case since the 26th of May. So they are on their way to be declared under control. But within Ituri, which remains the epicenter, we still have active transmission happening with the 24 health zones affected out of the 36 health zones that they have. So epidemiologically, we are seeing some progress in terms of the overall case to contact ratio. We are seeing more contacts being listed now, and the contact follow-up rate is high. We are now at 82%, which is a very good progress from the 20% that we started with. But within Ituri, we still see a geographic expansion, which is the point of concern. And we really working to support the government to ensure that we can scale up the response activities, particularly focusing on risk communication, community engagement, so that more people can continue to come to the treatment facilities, and that the communities can continue to accept the public health measures that are being implemented.
Now, I remember from when we last spoke to you, one of the challenges that you did mention was obviously early detection, but delayed contact tracing. What other obstacles are you facing? What progress have you been able to make, and what still remains an obstacle? Because Bundibugyo, as we mentioned, itself has its own fingerprint.
Yes. So yes, some of those challenges are easing off, but they still remain. Early detection is still a problem. We still have people that are presenting very late, or others that are still dying within the communities. So early detection remains a major challenge. But I would like to emphasize that we've seen market improvement in terms of the uptake and the acceptance from the community. So there are more alerts, that is the people reporting that they have symptoms or symptoms that are similar, or communities reporting about that. So those are very good signals that we are seeing from the community. The other challenge we had was the testing, because we didn't have enough field or decentralized laboratories. Now we have up to 10 field laboratories that are testing. So initially we could only do like 30 tests per day. Now we can do up to 2,000 tests per day, which is a very good improvement. You have also seen that the recoveries, we are seeing more people recovering from the treatment centers that we have. We have expanded. When we spoke, we had like 300 beds. We now have 700 beds available in 22 treatment facilities, and we hope to get to 1,000 beds available by the end of this week. So we have 254 people that have recovered. And the good news this week was also we started the clinical trial for 2 therapeutics that are being assessed to see if they can help to improve the clinical outcomes. So those are really very good progress that have been made. Of course, our major challenge remains security and access. There are parts of Ituri that are not fully accessible for the responders, which remains a major hindrance really to the progress of this response.
And it's great news to hear that there is some sort of um, mitigation measure that is being worked on. But laboratory capacity was something that I know was of concern. Can you tell us a little bit more about that? And given the fact that you had mentioned and in your scenario planning, Bundibugyo was not something that you were looking at. So there is institutional knowledge of other Ebola outbreaks. How does it relate to this one and how to get ahead of it?
Yes, so the challenge we had at the onset with Bundibugyo was that we did not have field diagnostic capacities that we could use, and the most of the point of care use diagnostics like Gene Expert that we had was only adapted for the Ebola Zaire species. But we have had one platform that has been rapidly scaled up, which is called the RADI1 platform, which helps us to do tests in closer settings, close to the patient. So we have expanded that across Ituri and all different locations. So that's why I told you now we have, previously we would have to take the samples to Kinshasa or INRB Goma for testing where there are the PCR capacities, but now we are doing that across 10 different locations within Ituri, North Kivu, and South Kivu. So that has helped improve our turnaround time. Now we get results out within 24 hours. Now, the lesson from the previous outbreak, we did know, for instance, with the Ebola Zaire, when we had those Gene Expert cartridges, and you can do tests in different locations, even the treatment facilities closer to the patients, it really helped improve the time from detection to isolation to initiation of care to making clinical decisions. And it's something that we are using in this response. That's why we are expanding that the deployment of the RADI1 platforms so that we can do tests very fast. And it has, as I said, in the last few weeks, really been a game changer that we can do tests quickly and get the results out to the patients, but also to the clinicians who need to use it to make decisions.
What are other epidemiological indicators that you're looking for to show that the response is working?
So one of the things we have talked a lot about the contact follow-up rate, which is why we want to get it to 95%. But other than that, we have also been looking at among the new cases that are being reported, ideally as our case investigation listing of contacts improves, you expect to get more cases who are already known contacts that were under follow-up than cases for which you don't have any epidemiological link. Now, by last week, we were at 41%. That 41% of the new cases were coming off contact list. We want to get that to 100%, so that every new case that comes up is already a contact that we knew about, that we were following, that was adhering to public health measures. By doing that, we reduce the risk of further spread beyond the area where these contacts are located. So it's an important epidemiological indicator that we are looking at. The second one is also the number of alerts that we get on a daily basis. Our surveillance system needs to be very sensitive so that we can pick up any suspected case, whether somebody is presenting with symptoms or somebody has died with symptoms that are suggestive of Ebola. We need to be able to pick this quite quickly from the community and then have them investigated and tested accordingly. So the number of alerts on a daily basis is an indicator of how sensitive our surveillance system is, but also is an indicator of how the community is responding to our messages. So now we have a very high number of alerts. We are getting in a day sometimes over 600 and 700 alerts. And once we get these alerts, we need to have all of them investigated on the day. All of them, for those who meet the case definition, samples need to be collected and the results need to be available within 24 hours. Those are the other indicators that we are looking at so that we maintain a very sensitive surveillance system that can be able to pick any new case and respond very, very rapidly.
And I want to talk about that, the quality of surveillance, what matters, particularly the invisible transmission chains, the cases that you don't know about, how they present, etc.
Yes, so when we enhance surveillance across an area where we have an outbreak, we also put in place what we call zero reporting. So from every health zone which is at risk and those that are surrounding, we encourage that even when you have not seen a suspected case today, you need to be able to report your zero for that day. That will show us that the surveillance has not gone to sleep, it's also working. Now, surveillance, usually in this context, we have three arms. We have the indicator-based surveillance that is based in the health facilities, where we expect the clinicians, when they see any suspected case, they report. But we also have the most important component, which is the community-based surveillance, using the community healthcare workers with a simplified case definition, moving around, trying to see if there's any report of somebody. Usually we give them simple symptoms like headache, fever, joint pain, severe weakness, or somebody who has died of an unexplained cause. Then from the community, they can pick that and report, and we investigate. But during Ebola also, we add a third component, which is the mortality surveillance, so that even people who die from any other source or cause of death, or they are at a funeral parlors or different mortuaries, that we are able to test those, collect postmortem sample and test, so that we don't miss any person who didn't present to the facility and died at home. So all those three components have been activated and are working, and we analyze every week to see if there are any areas from which we are not receiving this data. Then we deploy teams to go and find out what's happening in this area, because that could be an area where there's silent transmission. And usually silent transmission, we pick it from the mortality surveillance, because if people are not reporting when they are sick, you can then pick when somebody has died. When you pick postmortem samples and test, you can be able to identify that.
And just in terms of epidemiological behavior and donor psychology, because the communities we'd also spoken about, there is fear and lack of trust. What are you noticing, and is there a difference between this outbreak and other outbreaks that could help further understand the nature of Bundibugyo and other possibly further hemorrhagic fevers that may become outbreaks?
Thank you. Now, one thing that I always emphasize, that every outbreak, either of Ebola or any other viral hemorrhagic fever, is unique. So you can have so many outbreaks, but every outbreak happens in some context, and that makes it unique. So for this particular one, for instance, this outbreak is happening in an area where we've had insecurity for a very long time. So there are a lot of contextual issues that compound some of the things that we know about Ebola. Now, the second issue is that we have seen the clinical presentation for the Bundibugyo. And most times, one thing that shocks people when we deal with viral hemorrhagic fever is when they see their person presenting with bleeding, because it's a very scary thing and many people fear seeing blood. But for this species, for which a few proportion of the patients present with the bleeding, so many people will say, no, this is not Ebola, because they have not seen the bleeding. And sometimes it's because bleeding is a late stage manifestation. Some of the manifestation happens when the people have already been isolated and they're in the treatment center. So the community don't see that. What they see is the headache, the joint pain, the weakness, the vomiting, the diarrhea, which could be common in other diseases. So that is one of the challenge we've been dealing with, because people will say, no, this is not Ebola, it is something else. And then, of course, I have been saying in this context, we cannot talk so much about the case fatality ratio, which is usually very high in the other species of Ebola. But for this one, even now where we are with the case fatality ratio that we are seeing, it's already a very high number. We are talking of over 500 people that have died since this outbreak was declared on the 15th of May. So it's a very high number when we look at that. Now, the confusion we have, the last one I'll talk about, is also the absence of the countermeasures. So people have known, and we had outbreaks in this area the last time, and we were able to vaccinate because we had vaccines for the Zaire species. For this particular one, we don't have a vaccine, and there have been concerns from the community why we are not vaccinating the population, because that could help control the outbreak faster. And that's an area that we hope the research will help us to answer
And
soon.
I hope we have a lengthier conversation about that. Unfortunately, we have run out of time now. Dr. Patrick Otim Ramadan from the WHO Afro. It's gone 8 o'clock time now for your news. Back to Nolutando Butelis.